All right, our patient demographic could be a male or a female, so I'm going to include the female here. We're now in question 161. Again, all these questions are completely original. I've made them for you to prepare for step 1. They're not copied from the NBME, but it's everything that you need to know by the time you finish your preparation for step 1. So here we go. 55-year-old woman, history of major depressive disorder and chronic alcohol use is admitted for severe nausea and fatigue. Lab show low sodium, and she started on intravenous saline therapy. 3 days later, she becomes unable to speak and shows profound weakness in all limbs. Neurologic exam reveals an awake and alert patient with dysarthria, bilateral Babinski signs, and marked quadriplegia. Sensation and eye movements are intact. Which of the following structures is affected? The answer, as you can see, is the pons. The reason why this is osmotic demyelination syndrome, here I've taken some notes as I've gone through all these questions beforehand, but the big thing you should know is somebody walks into the clinic and they've got super severe hyponatremia, and then they're started on some saline therapy, 0.9% saline, and then later they develop dysarthria, which is the difficult or unclear articulation of speech that otherwise is totally linguistically normal. Also quadriparesis, which is weakness or paralysis in all 4 limbs, so arms and legs, quad, and the Babinski sign. And all these symptoms should make you think of a brainstem issue, specifically in the brainstem, the pons, and it's classic central pontine myelinolysis, or CPM. This is also known as osmotic demyelination syndrome, ODS. And the pathophys is important to understand. When you have chronic hyponatremia and it's corrected way too rapidly, then water is going to shift out of the brain cells, and that causes demyelination, particularly in the pons, because the pons has the corticospinal and the corticobulbar tract and the corticobulbar tracts. So that's what causes the dysarthria, dysphagia, the locked-in syndrome if it's super severe. So this is a question in neurology about demyelinating disorder. Let's talk about what it's not. Internal capsule, that'd be motor stroke. That would cause hemiparesis, not quadriplegia with dysarthria. Pure motor for internal capsule. Internal, I just want you to link that to motor. Cerebellar vermis, that would cause some truncal ataxia. Probably shouldn't move away from the mic to demonstrate what that looks like. But there you'd have preserved eye movement. The medulla, that would be involved in cranial nerve 9 to 12 dysfunction, not locked in. So you should think respiration issues would be seen there. Basal ganglia would have movement disorders like chorea and rigidity. All right, so there's our guy. There's our patient. They got the slurred speech, quadriplegia, Babinski sign. That's what you should look out for. And I wanted to make an image so that you guys can kind of see this in your mind, because all these test questions can feel pretty abstract, but you should pretend each test question is a new patient. And now I really want to break down some specifics here. You might have also been tempted to put something like myasthenia gravis, or say that this is related to the neuromuscular junction. It is, however, not related to the neuromuscular junction, because disorders like myasthenia gravis do not cause upper motor neuron signs, and that's what Babinski's reflex is. Plus, this would have no connection to sodium, which was our big clue. You might have been tempted to put Guillain-Barré syndrome or something like that, like a peripheral nerve disease, but that presents with areflexia and ascending paralysis, not upper motor neuron signs, and a normal mental status. By the way, my favorite artist, Sufjan Stevens, had Guillain-Barré syndrome, so look that up if you're curious. It's good to have an anchor in your mind about these things. So yes, this is osmotic demyelination syndrome, and the actual cause is the rapid correction of the hyponatremia. You would see acute paralysis, dysarthria, dysphagia, locked-in syndrome. And the way that you remember this is you say this phrase in your head. From low to high, the pons will die. All right, so put that on a t-shirt. From low to high, the pons will die. Rapid increase of the sodium causes CPM. Now, quick recall drill. And by the way, in the comments, let me know if you want me to go into this much depth or if you prefer that I go quicker. But just a quick recap, which tracts are affected in central pontine myelinitis? The answer is the corticospinal and the corticobulbar. The next recap question, what is the safe rate for sodium correction? We mentioned this was too quick, so how quickly should you do it? Well, the answer is about 6 to 8 milliequivalents per liter per day, and some sources can say it's up to 10 to 12, but lower is going to be safer for chronic hyponatremia. All right, so the big tip that I would give you with this question is anytime you see an alcoholic or a malnourished patient that has severe hyponatremia and they have neurologic symptoms after the sodium correction, then you should immediately be thinking of osmotic demyelination syndrome. And the first time I was going over this question, I drew this out for you guys too, so you can see low sodium. By the way, if this is helpful, please consider liking and subscribing. Videos take dozens of hours to make, and I'm doing it so that you have another way to study for step 1, step 2, step 3. Let me know in the comments if you like the patient photo and also a relevant demographic photo. All right, let's not waste any more time. Next question. But basically, we got a 45-year-old man presenting with a 6-month history of intermittent chest discomfort. This could be a woman as well, hence my relevant demographic photo up there in the corner. Typically occurs after dinner, especially when he eats fried or spicy foods. He has gained 20 pounds over the past year and often lies on the couch shortly after meals. He denies weight loss, difficulty swelling, and gastrointestinal bleeding. He has tried over-the-counter antacids with partial relief, and physical examination is normal. Which of the following mechanisms is most likely contributing to his symptoms? Okay, we have a couple of options here. We have to understand what's going on. So the symptoms are postprandial burning chest pain that worsens with large or fatty meals. The timing, they don't really mention this in this question, but typically it's daytime and it worsens after you have fried foods. And antacids were great, but now it's refractory. There's no dysphagia, there's no weight loss, there's no bleeding, and the history has maybe some recurrent symptoms. If this is a female, you might see this happens whenever she's pregnant or something like that. And so we should have a differential diagnosis list, and one of the top differentials should be gastroesophageal reflux disease, GERD. You heard with PERD. Just kidding. That's a Parks and Rec quote. But this is GERD, and so the answer is going to be vagal stimulation causing transient lower esophageal sphincter relaxation. And the pathophys is important. The lower esophageal sphincter normally prevents acid from refluxing up. And so if that's too relaxed, the vagus nerve is mediating that transient lower esophageal sphincter relaxation after meals. If it's too relaxed, then it allows the gastric contents to then enter into the esophagus. And so fatty foods, large meals and chocolate, that kind of stuff, increases these relaxations, and repeated acid exposure causes mucosal irritation. And then that's what causes the symptoms of heartburn and regurgitation. All right, so here's the explanation. I've kind of said most of this already, but it's triggered by the vagal pathways that help it to relax to allow the gastric contents to reflux into the esophagus after lying down or having fatty meals. Why is it not somatostatin-induced decrease in bicarb? Well, that inhibits the acid, not bicarbonate, and so it helps not hurt. And it asks what's contributing to this. And so somatostatin is actually helping, not contributing to that. Gastrin overproduction, pepsinogen is not the driver. Acid reflux is. Secrete-mediated inhibition of gastric acid secretion that would reduce the acid alleviating symptoms, and CCK-induced gallbladder contraction would involve fat digestion. All right, so here's a relevant photo of the patient. Again, let me know if you think this is helpful, and I'll start to include it in the future. There are some things to know, and one of those things is gastrin actually increases the lower esophageal sphincter tone, and that helps to prevent the reflux. And so it's protective against GERD. So gastrin is not the right answer. Somatostatin inhibits gastric acid secretion. And so that's not the answer either. Vagal inhibition would be wrong because vagal nerve stimulates esophageal peristalsis, does not inhibit it. And so GERD is not due to the impaired esophageal contractions. It's due to the lower esophageal relaxation. So the key takeaway for this question is it's obviously a GI question about the esophagus, and it's GERD. GERD is the word. GERD is the word. Transient lower esophageal relaxation, fatty foods, caffeine, alcohol, chocolate, large meals, that kind of stuff. Barrett's esophagus could be a complication that you see from this. Esophagitis and stricture, and also adenocarcinoma. And the treatment is lifestyle change, proton pump inhibitors, and anytime that you're taking this silly test and you see postprandial heartburn that is worse with fatty acid foods and it's GERD, you should think of the lower esophageal sphincter dysfunction. Now, another question they could ask, we can't cover everything, but we can try to flesh out these topics as well as possible. Which neurotransmitter mediates the lower esophageal relaxation in GERD? And the answer is nitric oxide, which is released by vagal stimulation, is the neurotransmitter that mediates that lower esophageal sphincter relaxation. What is the most dangerous long-term complication of GERD? Well, this is actually going to be via that Barrett's esophagus pathway that I mentioned. It's esophageal adenocarcinoma. And adenocarcinoma is just a fancy way of saying a malignant tumor that's formed from the glandular structures in epithelial tissues. That's what adenocarcinoma means. All right, question 163. Here we have a 72-year-old woman, could be as like a young boy, an adolescent, as you can see here in this photo. Just want to make sure you're not super locked into this demographic. But they are admitted to the ICU with altered mental status, hypotension, and high fever. Her blood pressure remains low despite receiving aggressive IV fluid resuscitation. A norepinephrine infusion is started. The agent primarily acts by increasing vascular smooth muscle tone through stimulation of what? All right, let's get the lay of the land. If we have a patient who comes with shock, then we're probably going to want some vasoconstriction. And a great vasoconstrictor is the alpha-1, and indeed, norepinephrine in things like septic shock is going to target the alpha-1 receptor, causing vasoconstriction. And it also causes some beta-1 effects as well. And by the way, the shock type that is best treated by beta-1 stimulation is cardiogenic shock. That's where you have the low cardiac output. And the receptor that causes vasodilation of the renal arteries at low dopamine doses is the D1 receptor. But what you should think of for this question is alpha-1 agonists like norepinephrine or high-dose dopamine are good for treating septic shock or situations where you have increased SVR. And so if you see vasodilation and bounding pulses and warm extremities, then you should probably be thinking of septic shock. Another word for this is distributive shock, and that's where you have the vasodilation. And so how do you treat all that vasodilation? Alpha-1 agonism, because that causes vasoconstriction. All right, so norepinephrine exerts its primary action in stimulating alpha-1s, causing vasoconstriction. This raises SVR and is helpful in septic shock. Dopamine 1, that causes renal vasodilation, but it's associated with the renal perfusion. Beta-1 adrenergic receptors increases heart rate and contractility. Beta-2 helps with bronchodilation, vasodilation, and alpha-2 activation leads to decreased norepinephrine release, lower BP, and is harmful in shock. All right, so those are the explanations. And this is important because sepsis is one of the top causes of death in the ICU. And if you start them on an early vasopressor, it could save their life. And the problem with septic shock is that the vessels are way too relaxed. And the reason why is because they have cytokines like TNF-alpha and IL-1, and they're causing widespread vasodilation. So fluid resuscitation is really important, but if it stays low, if the mean arterial pressure still stays low, like let's say like under 65, then it's time to introduce a vasopressor. And norepinephrine is the hero drug there. And the reason why is because of that alpha-1 agonism. And those are GQ coupled receptors. And they activate then phase C, and that clamps down on the vessels to make them go tight. All right, so there's the image of our patient. You can see altered mental status. He's got his IV in there. He's undergoing septic shock. All right, and our next question, we have a 7-year-old girl running barefoot and her family lawn accidentally scrapes her foot on a sharp sprinkler head. Within 20 minutes, her right foot becomes swollen, warm, and red. Physical exam shows localized tenderness and fluctuant edema. Which of the following best explains the mechanism of fluid accumulation? All right, so we have some localized edema within 20 minutes, within 30 minutes. What's the primary mechanism at play? Now you can see this in a lot of different scenarios, but here we have histamine-mediated endothelial contraction. And this is due to reversible gap formation in the postcapillary venules. And that gap allows leakage of plasma proteins and fluid to go into the interstitial space. And that causes exudative edema. All right, so trap answers, VEGF, that would be involved in chronic processes and cancer, not acute stuff, but it would increase the permeability, just not acute, for direct necrosis. Increased hydrostatic pressure would be heart failure or DVT, that's a transudate, not exudate. And immune complex deposition would be a type 3 hypersensitivity, which would be more systemic or delayed. All right, so you stub your toe, get a scrape. First responders are the mast cells, releasing histamine. Then it opens up the small gaps. Histamine binds and triggers cytoskeletal contraction, making the wall leaky. And then the fluid and the immune cells spill out, so you get warmth, redness, and swelling there. It's the endothelial gap formation. All right, so there's an example of our little patient. Now you could also see this if somebody gets stung by a bee, for instance, then the bee venom can actually contain phospholipase A2, which disrupts the cell membrane and it activates arachidonic acid pathways, and that actually triggers a mast cell activation. So a similar kind of mechanism that we were talking about, and that mast cell degranulation causes the release of histamine. So now we got histamine, and histamine causes vasodilation, so that improves the blood flow. So if you get stung by a bee, you get increased blood flow, but you also have edema because you get contraction of the endothelial cells. That causes the gaps to form, the intercellular gaps. That increases vascular permeability, and you get fluid and protein leak into the interstitium. So that's localized swelling and edema. All right, so here are some buzzwords. Endothelial contraction, histamine, bradykinin, transudate versus exudate. Got to watch out for the histamines, leukotrienes, increased permeability, and there's the pathophys. Some things to look out for, some topics that you need to know for step 1 is how to distinguish this from demargination. And that's what happens with cortisol and steroids or stress, and this does not cause edema. You should know fibrin, that's involved in the clotting, not going to be involved in a sting. Vasodilation increases blood flow and also redness and warmth, but it does not increase vascular permeability. So it's not just vasodilation. The question is really getting at the gap junction formation. So this is kind of an immunology, inflammation question, and the vascular changes that you see there. So histamine causes endothelial contraction. That increases permeability, leading to exudate, which is protein-rich accumulation, and it's seen in the early phases of inflammation. So histamine, bradykinin, leukotrienes, CDE4, this contributes to endothelial cell contraction, gap formation in the postcapillary venules, increased permeability, exudation, and edema. So a quick rapid recall for you, just to make sure you got this. Which inflammatory mediator causes both vasodilation and increased vascular permeability? Well, the answer is, of course, histamine. Yay, we learned something. What type of vessel is most affected in inflammatory fluid leakage? Well, that is the postcapillary venule. And what's the difference between exudate and transudate? Exudate is going to be protein-rich, and that's due to inflammation because of increased permeability. Transudate is protein-4, and that's because of hydrostatic pressure or decreased oncotic pressure. So if they ask about localized edema after some sort of a sting or allergy, then it's going to be histamine, endothelial gap junctions. That causes exudation. All right, this next one is just kind of like an ethics principle here. Always apologize, even if it's not your fault. Apologize because they're feeling bad. Don't ever make any excuses whatsoever. Don't try to explain or say, oh my gosh, it's all Bob Jones's fault. Just say, hey, I'm sorry, my bad. And then focus on whatever concern they have. Don't get caught up in the weeds of your own ego. Just apologize, no excuses. All right, that's ethics. Next. Okay, on to our next practice question. Here, a 73-year-old man, could be a woman as well, goes to a primary care physician with fatigue and lightheadedness when walking uphill. He denies chest pain, reports occasional near fainting spells. On exam, his carotid pulse is slowly rising and weak. Carotid auscultation reveals a harsh systolic murmur lattice of the second right intercostal space. Radiating toward the neck, there's no peripheral edema, and echocardiogram shows concentric left ventricular hypertrophy with normal ejection fraction. Which of the following is the most likely cause of his symptoms? Okay, so here's our guy, so you can see. Well, he is an elderly patient, and so the answer is going to be calcification of the aortic valve leaflets. Basically, aortic stenosis due to calcific degeneration. We know this because of the crescendo-decrescendo murmur, carotid radiation, and delayed upstroke. Now, the symptoms you might have to look out for on test day are fatigue, lightheadedness, especially if they're exerting, and near syncope. The exam would show a slow, rising, weak carotid pulse. There's also a harsh systolic murmur at the second right intercostal space, and that radiates to the neck. And you have concentric left ventricle hypertrophy with normal ejection fraction. All those signs kind of point toward aortic stenosis. And the key finding really in aortic stenosis is the crescendo, decrescendo quality in the second right intercostal space, because that's the location of the aortic valve. Slow rising or weak pulse, like pulsus parvis et tardis, that's high yield for aortic stenosis as well. And the pathophys for this is actually pretty simple. We basically just have a stenotic valve. And that causes resistance to outflow, and that leads to pressure overload. And so the left ventricle compensates with concentric hypertrophy, and that preserves the ejection fraction at first. And eventually you have decreased CO2 on exertion, and you get syncope and fatigue and angina. So this is kind of like a heart murmur cardiovascular question. And the triad to look out for, you can remember by saying it's SAD if somebody has aortic stenosis. That's because of pulmonary congestion as the left ventricle pressure starts to back up. And really it's unique because it radiates to the carotids. All right, here's some trap answers. Myxomatous degeneration of the mitral valve would have a click, late systolic murmur, seen in mitral valve prolapse. Rheumatic fusion, opening snap, diastolic rumble. Infected destruction of pulmonic valve, that'd be a diastolic murmur with IV drug use. And papillary muscle rupture, acute mitral regurg with hypotension and flash pulmonary edema, usually post-MI. All right, so the most common cause of acute stenosis in the elderly is calcific degeneration, known as senile calcific aortic stenosis. The type of murmur that increases with squatting and decreases with Valsalva is aortic stenosis. And the difference in left ventricular remodeling between aortic stenosis and aortic regurgitation is that in stenosis, you have concentric hypertrophy, pressure overload, and in aortic regurgitation, you get eccentric hypertrophy, volume overload. For the next question, we have a 68-year-old man with a history of BPH presenting to the emergency department with fever, dysuria, left-sided flank pain for 24 hours, experienced difficulty voiding, temperature 101, abdominal exam shows suprapubic fullness and left costovertebral angle tenderness. Urine dipstick is positive for leukocyte esterase, but negative for nitrates. Urine culture shows gram-positive cocci pairs and chains, which of the following is most likely? So it's gram-positive, and all these signs are pointing toward Enterococcus faecalis. We know this is like a urinary tract infection of some sort. We know that he has like pyelonephritis, and it's like a bug identification question, and it's gram-positive. And so I diagnosed this guy with acute pyelonephritis. And the pathophysiology is that we have a gram-positive cocci and chains. So our answer is C. Now, here's the explanation. But essentially, this organism is catalase negative, and it's part of the normal GI tract, the flora, and it can grow in bile and sodium chloride, and it's PYR positive. Now, you might be thinking, okay, well, I thought that the most common or whatever was E. coli, and you would indeed be right, but that is gram-positive. How about Shigella? You might have thought, okay, this is toast Shigella. No, because that's a gram-negative rod, and it causes bloody. Anytime you see Shigella, think blood in the urine. And it's not pyogenes, not strep, group A strep. That would be pharyngitis, cellulitis, necrotizing fasciitis, not a urinary problem. Klebsiella is gram-negative, and the mucoid colony is encapsulated. And saprophyticus, always think of young, sexually active females with UTI. It's rare in elderly men. So the demographic is different in that one. All right, next we got a 64-year-old man, could also be a woman, probably similar age, undergoing treatment for diffuse large B-cell lymphoma. His chemotherapy regimen includes anthracycline agent He initially responsible to therapy, but then later, after 6 months, he has progressive exertional dyspnea, orthopnea, and bilateral lower extremity edema. Physical exam shows bibasilar crackles, JVD, and third heart sound. Echocardiogram reveals dilated left ventricle and ejection fraction of 30%. What describes the mechanism? All right, so there's our new patient that fits this question's demographic. And the answer is going to be oxidative injury from free radicals. And we said anthracycline, but maybe it would have helped if you missed this question to know doxorubicin, which is an anthracycline and is commonly used, and that develops cardiomyopathy. And the mechanism of toxicity is what you need to know. So doxorubicin, any of like the rubicins will intercalate the DNA and inhibit topoisomerase 2. But the cardiotoxicity will be caused by iron-dependent generation of free radicals, and that leads to lipid peroxidation of the cardiomyocytes, and so you get myocyte necrosis and dilated cardiomyopathy. So the cardiomyopathy is dose-dependent, and the causes of dilated cardiomyopathy in this question is clearly from that anthracycline from the doxorubicin. So histologically, you have myofibril losses, vacuolization, which is the formation of vacuoles, the small membrane-bound sacs within the cells, and those can be a sign of cellular stress, and also interstitial fibrosis you might see. So really, a way to simplify this question is just a nice little easy farm question, and you're giving them some sort of like an anti-tumor antibiotic, doxorubicin, and that causes dilated cardiomyopathy, which is a dose-limiting toxicity. And you have free radical-induced damage to the myocytes. And so you could give them something like dexrazoxane, that's an iron chelator that prevents cardiotoxicity. Okay, some trap answers why they're wrong. Beta amyloid would be restrictive cardiomyopathy and amyloidosis. Calcium phosphate, dystrophic calcification. Immune complexes would be lupus, myocarditis. So doxorubicin enters the cardiac cells, goes through redox cycling, turns out reactive oxygenation species. They punch holes in the heart muscle cells, causing apoptosis and dilated cardiomyopathy. That's what we give them to protect. All right, now, some of you guys might be wondering about EGFRs. So EGFR inhibitors, like cetuximab, are actually going to cause a papulopustular rash, not cardiomyopathy. Papulopustular just means you have the papules, which are the small little raised bumps, and the pustules, which are pus-filled. So you get that redness, the flushing of the skin, the raised bumps with pus, and that's related to blood vessel dilation, bacterial overgrowth, that kind of stuff. It's not the abnormal myoglobin, because myoglobin release, anytime you think of myoglobin release, you should think of rhabdomyolysis, not chemotherapy induction. And vincristine would cause impairment of actin synthesis. That's vincristine's job. All right, in our next question, we have a 2-year-old male neonate born at 39 weeks gestation, noted for severe respiratory distress after birth. Physical exam shows nasal flaring, grunting, subcostal retractions, abdomen is scaphoid. Breath sounds are diminished on the right. Heart sounds more prominent on the left. Chest x-ray shows bowel loops occupying the right thoracic cavity with leftward mediastinal shift. Which of the following structures most likely failed to develop properly? And our answer is C, the right pleuroperitoneal membrane. I see this more as a memorization question, but typically you have like a full-term newborn. They got respiratory distress and they have abdominal contents in the thorax somewhere. It's congenital diaphragmatic hernia. And then you just have to memorize that congenital diaphragmatic hernia is due to that failure to fuse the pleuroperitoneal membrane with the septum transversum. That's what causes the hernia. It's that failure to fuse. And the thorax, by the way, is the part of the body on any mammal that's between the neck and the abdomen. And so it's usually referred to like the cavity that's enclosed by the ribs. It's like that breastbone area, that dorsal vertebrae. Usually it has the chief organs of circulation and respiration. So what happens in this little baby is that you have the compression of those developing lungs and pulmonary hypoplasia and respiratory failure. And so this is often associated with persistent pulmonary hypertension of the newborn. Think of this as an embryology question and diaphragm development question. It's a congenital diaphragmatic hernia because of the defective development of the pleuroperitoneal membrane, and that leads to pulmonary hypoplasia. And it's usually left-sided, and that's the reason being that the liver protects the right side. Okay, here are the trap answers why they're wrong. Septum transversum is rarely the sole defect here. Pulmonary endoderm affects lung tissue development. Pleuropericardial fold separates the pericardium and the pleural cavity. Cervical somites provide the muscle. So the diaphragm is kind of like a little quilt. It's made of pleuroperitoneal membrane, transversum, and somites. What happens here is that the abdominal organs slip through the hole into the thorax. Pulmonary hypoplasia. Now you can't breathe. Now the abdomen's sunken because the bowel's not in the belly. It's in the chest. Wild. Now some other answers you could see would be like the diaphragmatic crus, and that gives support, but it's not the site of the herniation. And septum transversum is what actually forms the central tendon. That's possible, but it would form the rare central hernia, not CD8. All right, now look at this absolutely adorable infant. 3-month-old male, could be female, as you can see here. Born at term, 9 pounds, has an enlarged tongue, prominent umbilical hernia. Asymmetry of the limbs and the right leg appearing longer than the left. Abdominal ultrasound shows heterogeneous mass of the right kidney. Genetic analysis demonstrates loss of maternal methylation through imprinting on 11/15. Which of the following best explains the pathogenesis of this patient's condition? Okay, so there's a little baby that represents this demographic in this question. Super cute. Pediatrics is the absolute best, by the way. Now, this is a condition known as Beckwith-Wiedemann syndrome, and a couple of things are seen here. One is excessive birth weight and maybe some postnasal overgrowth. They typically have a large tongue, macroglossia is that's super classic for BWS. They could also have that stork bite, but that could be kind of nonspecific. And one thing to really look out for that's super high yield that they're going to test you on is the abnormal mass. Wilms tumor. That's high yield for BWS. And there's a genetic mutation of 11p15. It's the abnormal methylation, which is a huge clue as well. And the pathophys here is that there's a loss of imprinting or uniparental disomy of that 11p15. And so that affects the insulin-like growth factor 2, which is the paternally expressed growth promoter, or could affect the maternally expressed growth suppressor. And so normally one parental allele is active, right? We're familiar with imprinting there. But in BWS, both alleles are expressed, and so there's overgrowth. So you're expressing IGF-2, which is the paternally expressed growth promoter, and you're also expressing the maternally expressed growth expressor. And imprinting is the epigenetic silencing of only one parental allele. And it's mediated by DNA methylation and histone modification. An example of that is Prader-Willi starts with a P, and so which one's deleted? The P. Angelman, what sticks out to you is the man in that, so it's maternal deletion. And Beckwith-Wiedemann is a biallelic paternal-like expression. It's not heteroplasmy, that's mitochondrial DNA variation. It's not anticipation, that's like Huntington's disease or myotonic dystrophy. It's not pleiotropy, that's one gene. So pleiotropy is one gene that affects many other systems. An example of that is PKU. And the most common tumor seen with Beckwith is Wilms tumor. So look out for the nephroblastoma, Wilms. And the gene that's normally maternally imprinted and overexpresses IGF-2. So it's abnormal imprinting. It's the loss of methylation on the maternal allele, and that causes biallelic expression. And so the answer is epigenetic silence failure. All right, so it's not Huntington's or Fragile X. That'd be triplets, mitochondrial heteroplasmy, variable expression, chromosomal non-disjunction. That's like Downs, and germline would be multiple affected siblings but normal parents. All right, here are the buzzwords: macrosomia, IGF-2 overexpression, nevus flammeus, port wide stain, common in syndromes involving overgrowth and vascular malformations, and Wilms, renal malignancy, macroglossia, big tongue, abnormal methylation, defect of the maternal. And so the maternal suppressor normally silences through methylation, but in BWS, the maternal methylation is lost, and so you can't suppress that gene. So you just get dad's growth factor. Mom was supposed to press the mute button. She didn't. And now the baby is playing twice as loud. I like that. Guys, thank you so much for watching these 10 questions. If this is helpful, please like and subscribe. We got a lot of amazing things coming on the channel. One of the biggest things is going to be a giveaway as soon as we finish our website. The website is going to be called ivmed.net. If you guys want to guarantee that you pass this exam on the first try, go ahead and get yourselves a tutor. Visit ivtutoring.net for that. Just fill out the form. Either way, I'll get on a call with you guys. I'd love to hear how you're doing, what you're struggling with, and help you along the way. I've got tons of resources to help you out with. This channel just scratches the surface. Also, make sure you're taking care of yourselves out there. If you're struggling, remember, no feeling is final. Tomorrow could be an amazing day. You can always reinvent yourself. Take it easy on yourself during this step period. This is an awesome opportunity to really crystallize your identity as somebody who works hard. You really can. And soon it'll all be over. Step 3 will be behind you, and you'll be able to save some patients' lives. We'll see you guys in the next video.